Welcome back to the Deep Dive. Today, we're plunging into a really important document you, our listener, brought to our attention. It's a brand new collaborative guideline on asthma, just released in November 2024.
Yeah, this one's a big deal. It brings together the British Thoracic Society, DIACE, and SAGEAN, three major UK bodies.
Right, aiming for one unified national guidance for the UK.
Exactly. On how to diagnose, monitor, and manage chronic asthma. Covers adults, young people, children. It's meant to replace those older, separate guidelines.
So one clear, consistent approach, that sounds needed.
It really is.
And that's where we're diving in. Think of this as your shortcut to understanding the core of this pretty complex document.
It is dense, yeah, but packed with crucial info.
It's based on the latest evidence aimed mainly at healthcare professionals, sure, but honestly, it's vital for anyone connected to asthma. And that includes you listening.
Definitely. Patients, families, carers.
So our mission today is to pull out the most critical insights, the practical takeaways, maybe some surprising bits straight from the source.
Get you up to speed quickly and thoroughly.
Exactly.
And it's worth saying, this is a living document, built on evidence now, but it'll be updated as new research comes out.
Good point. But for today, this is the current best practice.
Right.
Okay, let's unpack this source. We'll start with what it covers, then diagnosis, which looks quite specific for different ages.
The algorithms.
Then monitoring, how medications recommended. Some big shifts there, it seems.
Yeah, especially around reliever use and combination inhalers.
And finally, self-management, risk, care delivery.
Yeah.
Even what they say needs more research.
It's a lot, but we'll boil it down. You should end up with a really solid grasp of the key principles.
Perfect. Let's start with the foundation then. What's the exact scope? What's it trying to solve?
Okay, so the main focus is crystal clear: diagnosis, monitoring, and the long-term management of chronic asthma.
Chronic asthma. So not someone having a severe attack right now.
Correct. Not that immediate emergency situation. The
Yeah.
goal here is, 1, improve diagnostic accuracy, getting it right from the start. 2, help people get better control of their day-to-day symptoms.
Right.
And 3, ultimately cut down the risk of attacks happening in the first place.
And that distinction is important. It doesn't cover managing those acute attacks.
No, it specifically says it doesn't cover managing severe asthma or acute attacks. It points you elsewhere for that.
Yeah.
This is all about the diagnosis and the ongoing long-term control.
Got it. It was a huge effort, wasn't it? BTS, NACE, SAGEAN all working together.
Absolutely. British Thoracic Society, National Institute for Health and Care Excellence, Scottish Intercollegiate Guidelines Network. That joint development is key.
Replacing older, maybe differing guidelines.
Yeah, aiming for that single, unified approach across the UK. A big step for consistency.
And who is it really ready for? It sounds technical, but you said it's broader than just doctors.
Yeah, the primary audience is definitely healthcare professionals, GPs, nurses, specialists, but also people commissioning services.
Yep.
And crucially, like you said, it's explicitly for people with suspected or diagnosed asthma and their families or carers. That shared understanding is vital.
And that shared understanding links to another point. These are recommendations, not strict laws, right?
Exactly. Not mandatory. There's strong recommendations based on evidence, but doctors need to use clinical judgment.
Considering the individual patient.
Yes, your individual needs, preferences, circumstances. It's about informing decisions. Fits with shared decision-making, realistic medicine in Scotland, that kind of thing.
Right. Okay, let's move to that crucial first step. Getting the diagnosis right. Where does it start?
For everyone, all ages, it kicks off with a really structured clinical history.
So asking specific questions.
Yes, about key symptoms. Wheeze, noisy breathing, cough, breathlessness, chest tightness.
And not just if you have them, but when and how they change.
Exactly. They're specifically looking for variation. Are they worse at night, early morning, seasonal, triggered by exercise? That pattern is a big clue for asthma. They'll also ask about triggers, personal or family history of asthma, or things like allergic rhinitis, often linked.
And a really critical point the guideline makes.
Yes, a core rule, very clear. You cannot confirm an asthma diagnosis based only on history or symptoms. You need an objective test.
No objective test, no confirmed diagnosis.
Right. Until then, it should be coded as suspected asthma.
So history makes you suspect, tests confirm. What about a physical exam?
They'll do one. Look for things like expiratory polyphonic wheeze, maybe signs of other causes.
What?
But, and this is interesting, the guideline notes the exam can be totally normal even if you do have asthma.
So a normal exam doesn't rule it out.
Nope.
What if someone comes in really struggling to breathe right then?
If someone's acutely unwell, very symptomatic, priority one is treat them immediately.
Of course.
However, the guideline says, if possible, try to do the objective tests, FeNO, spirometry, PEF, right then, maybe before or after a bronchodilator, if the equipment's there and it's safe.
And if not possible right then?
Do them later, once things have settled. But there's a caveat.
Which is?
If they've already had inhaled corticosteroids, the test results might look falsely normal, so you need to factor that in.
Right, treatment can affect the tests. Treat first, but remember to test later. Okay, let's get into those objective tests. Different pathways for different ages, you said. Adults and young people, 17 plus, algorithm A.
Yes, a step-by-step sequence. First step, measure either blood eosinophils,
A type of white blood cell.
yeah, often linked to allergy and inflammation, or measure FeNO,
FeNO, remind me what that is.
fractional exhaled nitric oxide. You breathe into a machine, it measures nitric oxide. High levels can mean airway inflammation, common in asthma.
Okay, so step 1 for results. Eosinophils or FeNO? What level means diagnosis?
If the eosinophils are above the lab's reference range, or FeNO is 50 parts per billion ppb or more, diagnose asthma. Done.
So a positive on either of those can be enough right at the start. What if they're not raised?
If not confirmed there, step 2 is bronchodilator reversibility, BDR, using spirometry.
Spirometry. The lung function test where you blow hard into a machine.
That's the one. For BDR, you do the test, take a reliever inhaler dose, wait a bit, repeat the test.
Looking for improvement.
A significant improvement. Specifically, diagnosis, if your FEV1 forced expiratory volume in 1 second goes up by 12% and by at least 200 milliliters compared to before the reliever.
Both 12% and 200 milliliter.
Or if the increase is 10% or more compared to your predicted normal FEV1.
Okay, what if spirometry isn't available or there's a wait?
Then the guideline suggests measuring peak expiratory flow, PEF, twice a day for 2 weeks.
With a peak flow meter at home.
Usually, yes. That quick, forceful blow. If the PEF variability, the amplitude percentage mean over those 2 weeks is 20% or more, that also supports asthma diagnosis here.
And if all those tests, eosinophils, BDR, PEF variability, are negative, but the doctor still really suspects asthma,
Then refer for consideration of a bronchial challenge test.
that sounds more involved.
It is. You inhale substances to see if they trigger airway narrowing. If you show bronchial hyperresponsiveness, that confirms it.
That sequence feels very carefully planned. Why that specific order? Phenols first, then spirometry, PCF, challenge test last.
Yeah, the rationale explains it. The committee looked at test specificity, sensitivity, availability, how acceptable it is for patients, and importantly, cost effectiveness.
The economics.
Right. They favored this gradual rule-in approach. Use the less expensive, more available tests first. Bronchial challenge is more specialist, more costly.
Makes sense. Start simple if they mention challenges with cutoffs, too.
Yeah, like lab variation for eosinophils or how age and height affect FeNO. Setting one single threshold is tricky, but necessary for clear guidance.
Okay, clear for adults. How about children aged 5 to 16? Algorithm B, is it the same?
Similar, but with key differences. Testing kids is harder.
Right.
For 5 to 16s, you also start with FeNO, but the threshold is lower. 35 ppb or more for diagnosis.
35 for kids, 50 for adults.
Okay.
And they prefer FeNO first over blood tests here.
Yeah, if possible to avoid a blood draw.
Makes sense for kids. What if FeNO isn't raised or available?
Then measure BDR with spirometry, like adults. But the criteria are slightly different.
How so?
For this age group, diagnosis if FEV1 increases by 12% or more from baseline, or 10% or more of predicted normal FEV1.
So it's 12% or 10% predicted, not the 12% and 200 milliliters like adults.
Right. Reflecting maybe smaller lung volumes.
And if spirometry isn't an option for kids?
Same as adults. 2 weeks of twice daily PEF monitoring, 20% or more variability supports asthma.
Now, the next step for kids, if all those are negative, seems different. What happens then if you still suspect asthma?
This is where algorithm B diverges. If those initial tests are negative but suspicion remains high, you then consider either skin prick testing to house dust mite,
A common allergen?
very common, or measuring total IgE in the blood and the blood eosinophil count again.
How do those help diagnose asthma?
Well, interestingly, the rationale says these can help rule out asthma in kids before going to more complex tests.
Rule out?
If there's no sign of sensitivity on skin prick testing, or the IgE level isn't raised, the guideline says you can exclude asthma in this context.
Oh, okay.
But if there is sensitivity or raised IgE, and the eosinophil count is also high, over 0.5 by 109 liter if IgE is up, that strengthens the case for asthma.
So it works both ways. What if there's still doubt after all that?
Then, refer to a pediatric specialist for a second opinion. They might consider a bronchial challenge test, but it's further down the line for kids.
And the logic for this specific kid sequence?
The rationale notes testing is harder in children. Health economics suggested this rule-in, rule-out approach was best. Use those sensitive allergy-type tests later to potentially rule out asthma before needing the costly challenge test.
Got it. Very thorough for older kids. What about the under 5s? Diagnosing them sounds incredibly tough.
It is. Very challenging. Hard to get reliable objective tests like spirometry or PEF, and FeNO standards aren't as well established for them.
So if you can't rely on those tests, what's the approach?
It's more pragmatic. If a child under 5 has symptoms suggesting they need regular preventative treatment or they're having severe wheezy episodes,
Yes.
consider a trial of twice-daily pediatric low-dose inhaled corticosteroids, ICS, usually for 8 to 12 weeks.
The trial of treatment. And
Yeah.
then see what happened.
Exactly. Review regularly. If symptoms persist by age 5, try the objective tests from the 5 to 16 pathway.
And if they still can't do the tests at 5?
Keep trying every 6 to 12 months. And if their suspected asthma isn't responding to that trial treatment, refer for specialist assessment.
Is there a specific point where referral is definitely needed for under 5s?
Yes, a clear trigger point. Any preschool child under 5 with 1 hospital admission or 2 or more emergency visits for wheeze in 12 months should be referred to a specialist respiratory pediatrician.
Okay, that flags the higher risk early on, even without a confirmed test diagnosis yet.
Precisely.
So diagnosis covered. Briefly, occupational asthma in adults.
Key thing is to ask adults with new or worsening asthma if symptoms change away from work, weekends, holidays.
Better, worse, or the same?
Exactly. That pattern is key. If occupational asthma is suspected based on that, refer promptly to a specialist.
Right, a specific question to trigger referral.
Okay.
We have the diagnosis process. Once someone has asthma, how do we monitor their control?
Monitoring is vital. The guideline lists things to check at every review.
Such as?
Symptom frequency and variation, time off work or school, reliever inhaler use.
And check the prescription record for that?
Yes, definitely check the record. It's objective, more reliable than just asking sometimes.
Okay. What else?
Also check number of oral steroid courses needed and any hospital admissions or ED visits for asthma.
So if reliever use is high, or they need steroids often, control is poor.
That's the red flag. And if control looks suboptimal, the guideline says, pause. Assess other factors before just changing meds.
Like adherence, technique, triggers.
Exactly, which we'll come back to.
Do they recommend symptom questionnaires?
Yes, consider using validated ones like ACQ, ACT, childhood ACT at any review, a structured way to track symptoms.
Now, a really big change seems to be around peak flow, PEF monitoring.
Yes, this is significant. The guideline recommends against routine, regular PEF monitoring for assessing ongoing control for most people.
Really? Why the change from old practice?
The rationale points to studies. Didn't consistently show benefit for everyone, could cause anxiety. Some studies even hinted at a possible link to more attacks.
Wow. So no more daily peak flow charts unless there's a specific reason.
Pretty much. Only if there's a specific need, like for someone who's a poor perceiver of symptoms or if PEF is explicitly part of their action plan. Otherwise, not for routine monitoring.
That's a major takeaway. What about FeNO for monitoring control? Used for diagnosis, but ongoing.
For adults, yes. Consider FeNO monitoring at regular reviews and before and after changing therapy.
Why?
FeNO reflects airway inflammation, so monitoring it can help guide treatment adjustments, check if someone's actually taking their ICS adherence, and might be cost-effective in adults by reducing exacerbations based on some studies.
But less clear for kids.
The evidence for routine monitoring cost-effectiveness in children was less convincing in the studies they reviewed.
Okay, so FeNO in for adult monitoring, routine PEF out.
Yeah.
Got it. Let's move to treatment. What are the core principles before picking meds?
Huge emphasis on why asthma might be uncontrolled before just upping the dose.
Okay,
Before adjusting meds, you must check for other potential reasons.
such as?
Could it be an alternative diagnosis? Critically, check adherence, are they taking it? Check inhaler technique, are they using it right?
The basics.
Absolutely. Plus smoking, vaping, environmental triggers, occupational factors, seasonal issues, even psychosocial factors like stress.
So investigate thoroughly first.
Yes. And they also suggest checking FeNO again if it's available and control is poor. A high level might point to poor adherence or needing more ICS.
Check why before changing what. And that core rule about relievers.
Yes, probably the single biggest safety message, highlighted strongly. Do not prescribe SABAs, the blue reliever inhalers like salbutamol alone.
Never on their own.
Never on their own for asthma without also prescribing an inhaled corticosteroid, ICS.
Why such a strong stance now?
It's based on evidence from asthma death reviews. Relying only on SABAs is dangerous. They relieve symptoms short-term but don't treat the underlying inflammation,
Leaving the inflammation unchecked.
which significantly increases the risk of a severe, potentially fatal attack. So the message is clear. If you need a SABA, you must also have an ICS on board.
Fundamental safety point. And once treatment is started or changed, when do you review?
Review response after 8 to 12 weeks.
Let's talk inhalers. How do you choose the device?
It's not just the drug. Key factors are, can the patient use it correctly? What's their preference? Likelihood of adherence is higher if they like it.
Preference matters. Anything else?
Yes. Consider the device with the lowest environmental impact among suitable options. And does it have a dose counter?
Environmental impact? Interesting. And spacers.
Usually prescribed with metered dose inhalers, MDIs, the aerosol puffers, especially for kids. Helps get the medicine to the lungs.
Education is vital, but they really stress watching people use their inhaler.
Massively. Observe technique at every asthma review routine or unscheduled, every asthma consultation. When control worsens, when device changes, when the patient asks.
Wow, that's frequent checking.
It is, but reflects how crucial technique is. Bad technique means the medicine doesn't work, no matter how good it is. If they can't use one device, find another they can manage.
Makes sense.
Also, try to use the same type of device for preventer and reliever if possible. Keep it simple.
Okay.
And maybe an extra MDI SABA with a spacer for emergencies for kids under 12 who struggle with dry powder inhalers during attacks. Also, return old inhalers to the pharmacy.
Good points. What about smart digital inhalers?
The recommendation is not for routine use.
Oh, why not? Seems like tracking usage would help.
While studies show they improved adherence, yes, people remembered better,
Yep.
but it didn't consistently translate into significantly better asthma control outcomes. Plus, one study showed an unexplained rise in hospital admissions, and they cost more.
So more research needed.
Yeah, to see who might really benefit, maybe checking adherence before starting specialist therapies, but not for everyone routinely right now.
Okay, clear. Let's get into the medication steps.
Mhm.
Age 12 and over first. Algorithm C. Big change at the start.
Yes. For newly diagnosed, or those previously on SABA alone, offer a low-dose ICS formoterol combination inhaler. Formoterol is a fast-acting reliever.
So a combo inhaler used as needed for symptoms.
Exactly. Called as-needed air therapy, anti-inflammatory reliever. You get both ICS and reliever whenever symptoms hit.
That's a fundamental shift from just SABA reliever.
It is. Though, important note, as of NOV 2024, using many of these combos only as needed is technically off-label in the UK. Only some specific budesonide formoterol ones have that license, but the recommendation is evidence-based.
Okay. What if someone presents with really bad symptoms, not just mild?
If highly symptomatic or during a bad flare-up, start them straight on low-dose MART, maintenance and reliever therapy, single ICS formoterol inhaler. Use daily for maintenance and extra doses as needed for relief.
So they get background treatment plus relief from the same inhaler.
Right. Treat the acute flare first, maybe with oral steroids, then consider stepping down to as-needed air later if they get good control.
Okay, 12 plus starts with as-needed air, mild, or low-dose MART, more severe initially. If as-needed air isn't enough, what's the step up?
Step up to low-dose MART, so same inhaler, but now use daily for maintenance, plus still use as needed for relief.
Why MART? What's the big advantage?
Rationale highlights its simpler one inhaler, and studies show it reduces exacerbations and hospital admissions compared to separate daily ICS and SABA reliever.
Okay. If low-dose MART isn't controlling things.
Step up to moderate dose MART, same single inhaler approach, just a higher ICS dose. Rationale says moderate dose MART is better at cutting severe exacerbations than other moderate dose options.
What if even moderate dose MART isn't enough, assuming good technique and adherence?
This is a key decision point. Check FeNO and blood eosinophils again.
Yeah, inflammation markers.
Right. If either is raised high FeNO or high eosinophils, the recommendation is refer to a specialist.
Why refer specifically if those are high?
Because it suggests more severe or complex inflammation that likely needs specialist assessment and possibly biologic therapies, things beyond standard primary care.
And if FeNO and eosinophils are not raised, but they're still uncontrolled on moderate MART.
Then consider adding another medicine for a trial, 8 to 12 weeks.
Which ones?
Either a leukotriene receptor antagonist, LTRA, like montelukast, or a long-acting muscarinic receptor antagonist, LAMA. Add it to the moderate dose MART.
LTRA or LAMA. Try one, see if it works.
Yeah, trial one. If it helps, continue. Partially helps. Maybe add the other. Doesn't help. Stop it. Try the alternative one.
And remember the montelukast warning?
Yes, the MHRA warning about potential neuropsychiatric reactions needs discussion.
Okay. If asthma is still uncontrolled after moderate MART plus trials of LTRA and LAMA,
Refer to specialists. Definitely needs expert input at that stage.
what about people aged 12 plus who were on older treatments before this guideline?
Guidance is there to transition them.
Oh.
Someone on SABA alone, move to as-needed air.
Okay.
Someone on regular low-moderate dose ICS or ICS LABA plus SABA. Review and consider switching to the equivalent MART level low or moderate dose.
And if they were already on high-dose ICS?
Refer to specialist if still uncontrolled.
Right, that covers 12 plus ICS. Now, kids aged 5 to 11, algorithm D, how does their sequence differ?
Starting point is different. Initial management is twice daily pediatric low-dose ICS plus a SABA as needed.
So regular preventative ICS from the start for this age group, unlike the adult as-needed air start.
Correct. Rationale is regular ICS plus SABA is better than SABA alone for these kids.
Makes sense. What's the first step up if low-dose ICS plus SABA isn't enough?
Consider pediatric low-dose MART if the child and family can manage the regimen.
MART for kids, too.
Yes, but again, note it's off-label under 12 as of NOF 2024. But the rationale points to a study showing MART was superior for this age group, fewer exacerbations, less reliever use, fewer side effects.
Okay, what if MART isn't suitable or they can't manage it?
Alternative step-up is, consider adding an LTRA, like montelukast, for an 8-12-week trial. Stop if it doesn't work, remember the warning.
Right.
If still uncontrolled after considering trying LTRA, then offer twice-daily pediatric low-dose ICS LABA combo inhaler, plus continue SABA as needed.
So a combination preventer inhaler. And if that's still not enough,
Step up to twice-daily pediatric moderate-dose ICS LABA combo, still with SABA as needed.
when do kids 5'11 get referred?
If not controlled on pediatric moderate dose MART or not controlled on moderate dose ICS LABA maintenance with or without LTRA, depending on what's tried.
Okay. Finally, the under 5s, pharmacological management algorithm E, follows from the diagnostic trial.
Yes. As we said, if symptoms suggest need for maintenance or severe episodes, consider that 8-12-week trial of twice-daily pediatric low-dose ICS plus SABA as needed.
What if symptoms don't improve during that trial?
Crucial point. Don't just increase meds. First, check technique, adherence, environment, mold, smoke, etc. Reconsider the diagnosis.
Only refer if none of those explain it.
Yes. If none explain the lack of response, then refer to specialist.
Sensible. Don't escalate drugs if it's technique or triggers. What if the trial does work and symptoms resolve?
Consider stopping the regular ICS SABA. Review again in 3 months.
And if symptoms come back?
If they recur after stopping, or they have another bad episode needing oral steroids or hospital, restart regular ICS, low dose, titrate to moderate if needed, plus SABA as needed.
What if they're on moderate dose ICS plus SABA and still uncontrolled?
Consider adding an LTRA trial. 8-12 weeks, stop if no benefit, remember warning.
And if still uncontrolled after trying moderate ICS and LTRA?
Stop the LTRA if ineffective and refer to specialists.
So specialist referral is key when standard steps fail. Okay, meds are a huge part, but what about beyond inhalers? Self-management.
Very important. Adults, young people, kids 5+ FABA offer a structured program. Includes a documented, personalized asthma action plan plus education.
What goes in the action plan?
Clear steps for managing changing symptoms, but also minimizing exposure to triggers, pollution, smoke, and really stress reviewing understanding of the plan regularly.
Go ahead.
Hospital admission, acute visits, annual reviews. Check they get it. For under 5s, consider a plain education for family scarers.
Was there something about increasing ICS dose within the plan?
Yes. For adults 17+ on single ICS maintenance, consider including an option in their plan to temporarily increase ICS dose, maybe quadruple it, up to max license for 7 days if control slips per their plan.
But always know when to call for help.
Absolutely. Plan must include contacting healthcare professional if control worsens.
Are there things primary care teams can do to support self-management?
Yeah, lists several things. Computer alerts for reviews, structured protocols, pharmacist support, educational mailouts, phone calls, IT tools, community workers, especially for harder to reach groups. Also, school-based education via health school collaboration.
And risk-stratified care, was that?
Basically, identifying people at higher risk of bad outcomes, attacks, hospitalizations, and tailoring their care more closely.
What flags someone as high risk?
Things like poor adherence, using too many SABA relievers, 2 a year, needing frequent oral steroids, 2 courses a year, multiple ED visits, or any hospital admission for asthma in a year.
And identifying them helps.
Rationale suggests yes. Tailoring care for high-risk individuals, example, closer follow-up alerts, can reduce ED visit hospitalizations, likely cost-effective.
How should care be organized overall?
Primary peer review at least annually, and after any exacerbation, done by a trained professional, must include checking the action plan.
Telehealth.
Consider telehealth care or computerized decision support to help self-management, but needs more research.
Speaking of research, what were the key gaps the committee found?
Several big ones. Need more research comparing initial management for kids 5-11, fixed ICS plus SABA versus as-needed ICS for Motorol like adults use.
Okay.
Also, best step-up treatment for 12 plus after as-needed ICS for Motorol isn't fully clear.
And the diagnostic pathways.
Need research on their cost-effectiveness and feasibility in the real world across all age groups.
Digital inhalers and technique.
Need to know if digital monitors are cost-effective for improving adherence and who benefits most. Also, best way and frequency to check inhaler technique.
Adherence and stepping down.
Need cost-effective ways to improve adherence in those who struggle, and better ways to know when it's safe to reduce treatment in well-controlled asthma.
Anything else?
Yes, for kids, young people, is temporarily increasing ICS dose within an action plan better than sticking to usual dose when control dips? Needs study.
So there you have it, our deep dive into the core recommendation of this major new UK asthma guideline. We've gone through diagnosis.
Right, the structured history, the objective test sequences, FeNO, spirometry, PEF, tailored by age.
The shift in monitoring, away from routine PEF towards considering FeNO in adults.
And the detailed medication algorithms, the rise of MART and as-needed air, but still covering the standard approaches too, especially for younger kids.
And we didn't forget those crucial everyday aspects. Inhaler technique checks constantly.
It's absolutely critical.
Personalized action plans, managing asthma in pregnancy or adolescents, identifying high-risk individuals, and structuring care delivery.
Yeah, the goal was to give you the essentials from the source, the structure, the specific details like test thresholds, treatment steps, and the why behind key changes.
What really stands out, I think, is the level of detail for professionals, sure, but also how much emphasis there is on your role as the person with asthma or supporting someone.
Definitely. Your input on symptoms, using your action plan, getting technique right, sticking with treatment, the guideline makes it clear these are fundamental.
It's not just a doctor's document, is it?
Yeah.
It's really a roadmap for collaboration between you and your healthcare team.
That's a great way to put it. Collaboration is key to making this work.
Okay, so connecting this all to the bigger picture. It leaves us with a thought, doesn't it? We have this incredibly detailed, evidence-based guideline, huge focus on patient involvement, risk identification.
A real effort to improve care.
Yet asthma outcomes in the UK are still a serious concern. Preventable hospital stays, even deaths, still happen.
It's true. The burden remains high.
So the question to leave you with is, even with a blueprint this thorough, why might achieving consistently good outcomes for everyone with asthma remain such a persistent challenge? What other factors may be around implementing these guidelines, access to care, or things outside the direct clinical scope might still be hindering progress despite these best efforts? Something to mull over.